So my name is Lindsay, and for this proficiency video, I will be teaching you guys how to draw up IV syringe medications and administer it to my patient. So the first thing I have done this morning is I have checked my physician's orders against the MAR, and it says that I will be giving cefotaxime 235 milligrams IV Q8 hours for 10 days. Okay, so that looks good. I double checked that. I would have also gone in to see my patient just to check their IV site. There was no signs or symptoms of infiltration or phlebitis, so that was really good. I feel safe going ahead and preparing this medication. So the first thing I am going to do is I will gather my supplies, or actually I'll do a safe dose on what I will need to actually give my patient. So this patient is 4.7 kilograms and the baby is 12 days old. So in order to determine if I was going to use the neonatal profile versus the pediatric, I could have asked the expected date of delivery, or I could have checked the EMR to see how many weeks mother was when she delivered. This baby is under 45 weeks, so I have chosen the neonatal profile to go ahead. So according to the neonatal profile, it says route of administration's IV. I am to give, baby's more than 12 days, or is 12 days old, so I'm going to do more than 7 days, is 50 milligrams per kilo per dose, Q8 hours. So I would calculate it out, 50 milligrams times 4.7, which gives me 235 milligrams, which is exactly what the doctor's ordered, so I know that it is safe and it's within the therapeutic range. So going from there, I can gather my supplies. So I have my cefotaxime. I've got my sterile water for injection. Got my blood filter needle. I have a 10 cc syringe. Got a med label and some alcohol swabs. Perfect. So in order for me to determine how much of the medication I am going to draw up, I will take 235 milligrams, doctor's order that he's ordered, over X ml. The standard concentration, if I go across 1 gram, standard concentration is 100 milligrams per mil. So by doing my calculations, I can see that I'm going to prepare 2.35. I'll round that to 2.4. I am also going to draw up an extra mil just to account for the 0.55 cc's that's going to go into the line and to ensure that I do have enough medication to deliver to my patient. So I could say 3.5, even up to I think 4 would be acceptable, because again the safe pump will allow that only the 2.4 mil go into my patient. So first thing I am going to do is I am going to do some hand hygiene, and I'm going to get to my syringe. So I see that I have got the 1 milligram. I've double checked everything. 1 milligram, so 1 gram, 1 gram, which is 1,000 milligrams. I'm going to add 9.6 sterile water for injection. So what I need to do is I'm going to loosen this off, and I'm going to draw back to allow for 9.6 mils of air. Okay. I'm going to pop the top. It is sterile. If it was not, if the cap was off, I would have used an alcohol swab. Okay. So from there, I will. So there's a lot of pressure in here right now, so I'm just gonna slowly draw it back, getting rid of the air and bubbles as necessary. gonna draw a bit of air back just so it doesn't spray at me. A bit of extra water, I'll just get rid of that. Okay, so I feel good. There's no air bubbles. I've got my 9.6 ml sterile water. Next thing I'm going to do is I'm going to double check this medication. And I am going to insert that in. There we go. Inject. So there's a lot of pressure in here right now. Make sure all the bubbles. So I'm going to draw back some air once everything is in. That's right there. Okay. So I'm just going to passively recap that. And I'm just going to roll. Biggest thing with rolling is you want to make sure it's all mixing in with the water and there's no clumps to ensure that the dose is as effective as possible. So we're all mixed in there. So I know that I'm going to be withdrawing 2.4. So I'm going to draw back, let's say up to, we'll do 4 just to ensure. Of air. Okay. I am going to try and put it into the same hole. There we go. I probably would have alcohol swabbed that before I did that, just in case, because I did roll it. I feel like I probably should have alcohol swabbed that. I'm thinking now. So that is something I would have done for sure. Just in case I would have touched it when I was rolling, just to make sure that everything does remain sterile as possible. So I've injected the air in and I'm going to just draw back. Make sure there's no bubbles, there's a big one there. Okay. There's another bubble. So I'm just going to try it again here. That's better. And just double check air bubbles. So I've got 4. Okay. So at this point, I'll passively recap. I'm going to double check this with a nurse. So if I would ensure that my student or my clinical instructor was with me when I was doing this, but it's super important, especially for babies under 5 kilograms, that we do double checking our medications with the primary nurse or another nurse to ensure that we are within safe dosing. So again, a nurse would verify that this is the correct, this is how much I'm giving, and compare that with this dose, just to again ensure the safety of the patient, and she would be a co-signer as well on the MAR. So I feel good now going ahead and taking this off. Okay. Or actually, I'd leave it on. But I would prepare a medication label with cefotaxime, I would say which patient this is, the amount of medication that was put in, and it was added by me. I would strategically place this onto the syringe so that it sat properly in the pump, and that way the nurses or anyone else that was caring for this patient knew what I was actually giving. So yes, the med label would go on as well. From this point, I would go and take this to my patient's bedside, check the 2 identifiers, and the other thing I would be considering too, because I was paying attention to the adverse effects of it, just the diarrhea, vomiting. I would check the site before I went to administer again, and I would also do a follow-up after. It's just important that we are ensuring the patency of the veins and there are no signs or symptoms of infiltration phlebitis. I could ask the mother for any types of observational things that she has seen, if the baby's withdrawing their hand, any behavioral cues that might show that they're having pain to that site. So that is something else I would probably consider as well. I would go, again, prepared with the medication. Once it's drawn up, I would circle, take this to the patient's bedside, compare the identifiers, and program and pump with the assistance of my clinical instructor. And I think that's it.